and I guess I'd like to emphasize, on this point that really a lot of these patients the cycle length is so long. It's once every 6 weeks, and patients are coming from so far away. Right. So it's almost a forced collaboration, and in some ways, of course, very enjoyable. But a patient who's 8 hours away and having a toxicity from their radioligand therapy, you need to be in communication with the local physician. And so it has been a great opportunity for us to learn from each other. Often our community practice doctors are the ones seeing the side effect or the toxicity in that instance. And so I think it has been a really wonderful collaboration. And I was wanting to ask, as we were talking about this kind of PSMA PET and doing it at our center versus, I was going to ask you, Joelle, so in the community, do you find that when you're getting a PSMA PET, because we have these challenges when the PSMA PET comes to us, how do we predict if a patient is more likely to respond? So in the community, do you all kind of choose one center that you focus on, or is it that you're now kind of depending on these like weekly or every other week groups where you're meeting with nuclear physicist or somebody to kind of help overread those?
Yes, that's such a great point, because I think communication, the interoperability of sharing the data, the records, it speaks to that. So, the long cycle length, yes, it requires that the medical oncologist or the community oncologist have a touch base in the middle of therapy. And I've kind of copied the workflow that you have had with our local colleagues, and that is to assess the patient kind of mid-cycle to pick up on toxicities. Then there's the communication piece of the toxicities in case there's any dose adjustments or dose delays. But before any of that happens, there is the overread of the images. And so I think all of us might be, amateur nuclear medicine physicians, only in the sense of looking at the images and kind of attuning our eye. I use that more to investigate or ask questions to whether it's the radiologist or nuclear radiologist, about just learning and making sure that the patient's a candidate. And then that additional piece is that you have the imaging so that your colleagues who deliver the therapy in nuclear medicine can overread it, yes. And I think that's been at times a tricky point. And there's logistics to be worked out that I know can only get better, but that is really how we collaborate with our nuclear medicine colleagues, is reading them together, yes. And how do you proceed?
Well, I wanted to ask in particular, you brought up the mid-cycle scan.
Yes.
Are you in San Diego, UC San Diego, doing mid-cycle conventional or PET or variable?
I personally use conventional scans, the bone scan, CT, chest, and pelvis, pretty much mimic the region study. I tend not to use PSMA interval scans after 4 cycles, and I think the thing is, I don't really have good data to interpret what's the results going to guiding additional 2 cycles of treatments.
Right.
So I still rely on conventional scans for the interval monitoring.
Right. So that's always tricky too, because there are logistics and life involved. Yeah. So let's say I have a candidate who has already had the ARPI and a taxane, and we talk about being assessed for radioligand therapy. I have imaged with conventional scans, and so I have that imaging. And then the next is to get the PET PSMA, so there's a time lag. Then there's the time lag of a referral to a center. And then there's the time lag of therapy. And so by the time you treat with cycle 1, it has been a little bit of time. And just the logistics involved. And I have also tended to use conventional imaging because I can easily get that quickly. And I think that over time, it will evolve on how we interpret what's PET PSMA progression. And I think that, and just as we were getting ready to talk about radioligand therapy today, there's an interesting PCWG4 publication. One of y'all want to talk about that?
Yeah, I think that to Yue's point, we don't have the prospective validation of understanding, can we do an interval PSMA PET? I sometimes in my clinical practice, I am, and I don't know that I'm necessarily making treatment decision based on that, but really kind of monitoring the PSA and then monitoring some type of imaging. But yeah, there was a poster presented at ESMO just a couple weeks ago, and so I think groups are starting to try to understand this, to create the criteria to understand, what is progressive disease. So there, I think the group said if they see 2 new PSMA avid lesions, and if it's confirmed on the next imaging that would meet PD, and then to look at CR, so the complete resolution of prior PSMA avid disease, and that seemed to correlate with survival. So of course, I think this was based on a smaller phase 2 study that this criteria was designed, and the hope now is that we will have that, prospective validation of some type of imaging. So yeah, it is really interesting to see, even I think probably within our own practice, that people do it a little bit differently, and maybe depending on what the clinical features or the patient.
And I think it was literally a year ago that I think there was some discussion at the Euromigos conference last year,
Right.
which is when I talked with our total radioligand team, and I said, I'd like to start doing mid-cycle PSMA scans. Is everybody in agreement? And so for about a year, we've been doing it. And it's, it's not right or wrong at this point, in my opinion, but at least it's consistent. And we have actually gotten mostly good insurance approval for it. In the future, we'll hopefully have more data to support interpreting serial PSMAs. And
so how do you explain that to patients? Because they might be accustomed to, I have a high PSA, I have imaging with METs, we do this, and we assess with imaging and PSA. And so the conversation that you have with your patients about how to monitor responses, how do you do that?
Yeah, no, so I think the first thing is we see the trend of the PSA decreasing. That is probably the straightforward information, since we are following the PSA pretty much every cycle with the lutetium infusion. In terms of the imaging changes, I think as long as there is no growth, disease progression, and we in a setting of like PSA coming down, and I would continue additional 2 cycles to finish the total of 6.
Yes.
And I think, as most people would, if there's clinical concerns, new worsening pain, LFTs are rising, we definitely move up the scans as much as we're able to with scheduling, just to make sure that we're not continuing the radioligand if it's not effective for them.
Exactly, yes.